Good evening, everybody, and welcome to our webinar tonight, Take a Breath, Asthma, Medications and Devices. This is brought to us by the National Asthma Council. Our presenter tonight is Debbie Rigby. Debbie is an advanced practice pharmacist with postgraduate qualifications in clinical pharmacy, geriatrics and respiratory medicine. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on tonight and pay respect to elders past, present and emerging. Don't forget to type in any questions that you have in the question box, and we will certainly have time for a Q&A at the end. There won't be an evaluation that will pop up tonight, but in Debbie's last slide there's a QR code that you can scan to fill out an evaluation, and I will send you the link tomorrow also for you to fill it out. You will get a certificate though at the end of the session. All right, that's all you need to hear from me. I'll hand over to Debbie.
Okay, good evening everybody, and welcome to this webinar, yet another webinar. I don't know about you, but I'm a bit tired of webinars, but so hopefully we can make this interactive. As Jenny said, there is a question box, and I've got two screens, so I can hopefully juggle looking at these question box as well as the screens, and when I'm demonstrating the devices, I will switch to full camera mode. So you can actually see me demonstrating the devices. So I too would like to acknowledge the traditional custodians of the land and pay my respects to elders past, present and emerging. What we're going to go through tonight is focusing on the different classes of medicines used in the treatment of asthma and COPD, but the main focus will be around inhaler device technique. And we all know that patients struggle with remembering and using the correct technique. So it's very important that we know how to demonstrate these devices and use the devices correctly so that the patients can get the most out of their medicines. So I'll do a bit of background stuff, and then go through each of the devices one by one. So as you know, there's two main classes of medicines, and we call them relievers and preventers. Although if you read overseas literature, they tend to call preventers controllers, and the genus strategy talks about controllers. But the relievers we have are the short-acting beta-2 agonists, or SABAs. There's also short-acting muscarinic antagonists, or SAMAs, like Atrovent. Which aren't really used very much except by nebulizer in acute situations. And then our preventers, we've got the non-steroidal medicines, oral medicines, the montelukast, the leukotriene receptor antagonists. But the main treatment of asthma is inhaled corticosteroids, especially in adults and adolescents, so children over 12 years and over. And that is the mainstay of treatment. Not all younger children need to be on inhaled corticosteroids, but our guidelines, the Australian Asthma Handbook, as well as the genus strategy, all talk about inhaled corticosteroids as the mainstay of treatment of asthma. Getting patients to actually use them is another challenge for all of us. Then we've got long-acting beta-2 agonists, or LABAs, and long-acting muscarinic antagonists, or LAMAs. So I'll go through each of those classes and just mention the guidelines. Now, this is the National Asthma Council wall chart, and hopefully you've got them in your treatment rooms or surgeries. It is useful to have to show to patients because they quite often don't remember the name of their medicine, but might recognise it by colour or look and feel. And I'd have to say this chart, keeping these charts up to date is a nightmare. There's, three inhaler devices that aren't on this chart, and it will be updated in the next month. So you can see it's color-coded and grouped together, the SABAs. I will normally don't say trade names too much, but it's a bit challenging saying all the active ingredients when doing this sort of talk. And we should be thinking active ingredient and writing scripts for them. But we've got the SABAs, the Ventolins, Asmols, as well as Bricanol, terbutaline, which really isn't used as much, anywhere near as much as salbutamol. The ICS preventers, which are all listed there, LAMAs, which are only indicated, tiotropium respimat is only indicated or registered for asthma. The ICS LAVAs, which is probably what you're prescribing and seeing the most in the management of asthma. LAMAs by themselves, LAMA-LABA combinations, and then down the bottom is the triple therapy, so-called triple therapy ICS LAMA-LABAs. Trelegy, which at this point in time is only on the PBS for COPD, but it is registered with the TGA for asthma. So you could prescribe it, but not on the PBS. And we've now got 4 triple therapies. So Trimbo, which is on the PBS for COPD, but it's just or has a positive PBAC recommendation going to PBAC, so it's likely to be approved for asthma next month. And it's beclometasone, glycopyrronium, and formoterol. Then we've got Breztri Aerosphere, which is one of the newer technologies for the PMDIs, pressurized mid-dose inhalers. And what's missing? Enerzair, which is again only for COPD at this point in time, and it's mometasone, glycopyrronium, and indacaterol. So it is challenging. There are so many resources available through the National Asthma Council, as well as the Lung Foundation Australia. And you can see now everyone's so used to using QR codes that you can scan that QR code, and that's why I say it's good to have on your wall chart, scan it, and it'll go directly to the website for to show patients videos if you're not demonstrating it yourself. Mind you, I quite often do both. So looking at the different classes, you know, I'm sure you're all aware of all of this stuff, but it's just some reminders what we're talking about and the acronyms we talk about all the time. We've got the SABAs, short-acting beta-2 agonists, only use as needed. They work quickly and they work well, and that's why patients with asthma over-rely on SABAs for the treatment of their symptoms, because they know they get a positive effect within minutes, and it relieves their symptoms, the cough, the wheeze, the shortness of breath very quickly. And it is the mainstay when a patient's having an acute exacerbation, but as we all know, patients do over-rely on them and overuse them and underuse their inhaled corticosteroids. We have a number of different generics that are available. Unfortunately now, both Ventolin and Zemprion, which is the generic brand of Ventolin, have a dose counter. I think it's been a long time coming. I was actually born the year and month that Ventolin came to market, so it has been a while. And we, only just got dose counters on it now, which is pretty silly. And the side effects, and especially if people are overusing them or using it appropriately in an acute attack, is the tremors, the shakes, the palpitations, and hyperactivity in children. And this little diagram here is useful, and I use them in explaining to patients that SABAs work to relieve the bronchoconstriction, the tightening of the airways, but they do nothing for the inflammation or swelling and the mucus production. So helping patients to understand, yes, they're useful, very useful for that in an acute exacerbation, but the underlying pathophysiology of asthma is that inflammation and mucus production, and SABAs do nothing to relieve or prevent that. So we've got preventers. So we've got basically two types: the inhaled corticosteroids, and we've got lots of different molecules now, and the non-steroidal oral molecule, montelukast or Singulair, and a number of generics there. The most common side effect that patients experience with inhaled corticosteroids is the throat irritation, the oral thrush, and perhaps the dysphonia. Long term, because you can get some systemic absorption, especially if you're not using it well, and a lot of the inhaled corticosteroid is swallowed and goes into the stomach, and you can get systemic absorption there. You can also get systemic absorption from through the lungs. And that's why we should be using the lowest dose of inhaled corticosteroids that helps to control the patient's asthma. And again, as I said, this little diagram is helpful, explaining to patients that that's why the inhaled corticosteroids are necessary, to prevent and relieve that inflammation, swelling, and mucus production. So when we go through the, when I go through the guidelines, the Australian Asthma Handbook guidelines, it talks about low, medium, and high dose inhaled corticosteroids. And as I said, patients should be on the lowest dose that helps to control their asthma. This chart has just been updated in the Australian Asthma Handbook to include mometasone down the bottom. And I would stress that this is not a dose equivalence chart. What it's showing is what is considered low, medium, and high dose for each of the different inhaled corticosteroids. So don't go thinking that one equals the other, but it is an indication of what's considered low dose across these inhaled corticosteroids that are available. So our long-acting beta-2 agonists, they should only be used in combination with inhaled corticosteroids in people with asthma. They produce prolonged bronchodilation, either 24 hours or 12 hours duration. They shouldn't be used alone in patients with asthma, but I really don't see that very much these days at all. They should be taken regularly to reduce the symptoms, and people can still use their short-acting beta-2 agonists for any exacerbations. So the difference between them is the onset of action, really. Formoterol has a very quick onset of action, and it works just as quickly and just as well as the short-acting beta-2 agonists, and that's why it's now used in combination. The one we have is with budesonide, and you can use as needed budesonide formoterol because of that quick onset of action and twice daily dosing. Whereas salmeterol and indicatorol is once daily. It takes about 5 to 10 minutes to start working, and therefore can't be, and it's not approved for use in that acute situation. And the same with salmeterol, has an onset of action of about 20 minutes, twice daily dosing, and can't be used on a sort of PRN basis there. And the side effects are similar to SABA relievers. Yeah. Long-acting muscarinic antagonists, LAMAs, they're only approved for COPD. Tiotropium we've got as a Handihaler or Respimat and Spiriva, and the generic brand or the A-flag brand. So pharmacists can switch between the brands without contacting the prescriber, although in my opinion they should. They don't have to. And then glycopyrronium, imeclidinium, and aclidinium. And the way to remember it, and I teach into a few unis and tell students this, is look at the ending. The ending in inium is a bit, a trick to remember. All the long-acting beta-2 agonists, LABAs end in urol, whereas the LAMAs end in inium. We do have Spiriva Respimat, tiotropium, approved on the PBS for asthma, And for patients with moderate to severe asthma, that would also be on a high dose inhaled corticosteroid LABA and have had, under the PBS rules, one severe flare-up in the previous 12 months. Atrovent or ipratropium, as I said earlier, is really only used in acute severe asthma, usually as by nebulizers still. The LAMA-LABA combinations for COPD, none are approved for asthma. And you can see there the difference again is whether they're once daily or twice daily. Aclidinium is twice daily. And that can be beneficial in patients with COPD that experience early morning symptoms, shortness of breath on wakening, or waking up in the early morning with a cough perhaps, whereas the other three are once daily use. And then, as I said, we've got the triple combinations, the ICS LAMA-LABAs. NSAID Breezhailer is approved for asthma, severe asthma, once daily dosing, and they're different, two different strengths of the mometasone. These days, it is a bit confusing looking at these numbers because they're now TGA says they have to put both the metered dose and the actual dose sort of there. So it's challenging to remember the doses, but you can see the difference there. Trelegy Ellipta is another triple, and it's only for COPD, but as I said, it's registered for asthma, so you could prescribe it if whatever reason, on a private script for a patient with asthma. Whereas the other ones that are COPD, Trimbo and Breztri Aerosphere. The Aerosphere, I think, is interesting, newer technology, which does allow for greater lung deposition of the aerosol. Excuse me. The other medicines, the oral corticosteroids, prednisone and prednisolone, maybe rarely dexamethasone, are only reserved for severe flare-ups or exacerbations. If they're used for 3 to 5 days, which is recommended, there's no need to taper. Hopefully, the number of patients that need in short courses of prednisone or prednisolone is reducing, and certainly the need for maintenance doses in patients with asthma has significantly decreased because of the biologics that we've now got available for severe asthma. So omalizumab for allergic asthma, and mepolizumab, benralizumab, and dupilumab for eosinophilic asthma. And they have been shown quite conclusively that they're steroid sparing and really have been life-changing for people. There's around about 10% of the population with asthma that have severe uncontrolled asthma, despite being on high-dose ICS LABAs and perhaps LAMA as well. So big focus, and I think one of the interesting things, and there was an Australian paper on oral corticosteroid stewardship came out last year in the MJA and talking about the lifetime cumulative dose of prednisone or prednisolone being 1 gram. So that can be as little as 4 to 5 courses, short courses for an asthma flare-up. And that 1 gram cumulative dose over a person's lifetime, and some people will have that in a year, let alone over 20, 30, 40 years, is as sufficient to start causing the systemic adverse effects such as osteoporosis, cataracts, type 2 diabetes, cardiovascular side effects. So trying to reduce the need and certainly that need for maintenance doses of inhaled corticosteroids is really important. And I think, part of the issue, and that's what the handbook says, is that before escalating the dose of inhaled corticosteroids or going to the biologics, the MABs, that the patient's adherence to their inhaler devices and their device technique should be checked to make sure that they're using it appropriately and using it all of the time. So this is the algorithm in the Australian Asthma Handbook, and it's changed over the years. It used to be Christmas tree shaped with but now what it's saying, and this is really the fundamental change in asthma management over the last couple of years, and it's based on the trials around and the evidence around that over-reliance and overuse of SABAs in patients with asthma in adults and adolescents, and emerging soon-to-be published evidence in children 6 to 12 years old, and in particular the use of PRN, budesonide formoterol, low-dose budesonide formoterol, low-dose Symbicort as needed, so-called anti-inflammatory reliever. So in adults and adolescents, and I would stress I'm talking about adults and adolescents, only a few of them with very mild asthma, no flare-ups, need only as needed SABA alone. Whereas the majority, the most adults and adolescents with asthma should either be on a regular low-dose inhaled corticosteroid and a SABA reliever, or using PRN as needed, budesonide formoterol. And it's only budesonide formoterol because, as I said earlier, formoterol is the only one that works quickly. It works just as quickly as salbutamol and just as well for relieving those acute symptoms. So you've got choices, 2 choices, and Symbicort PRN has been on the PBS for a little while now. And then if patients aren't well controlled, still experiencing symptoms, having to use their SABAs more than twice a week, they should then be stepped up to a regular low-dose ICS LABA. I would stress it should be low-dose, or either using that regularly plus salbutamol PRN, or they can use the MART regimen, so maintenance and reliever therapy, as again, the only one we have is Symbicort, so using it twice daily as well as PRN. So throw away the blue puffer, throw away the SABA, and just using one device. So that's essentially the benefit, I think, and it's been shown to be just as effective as using ICS, a regular ICS, and the lower steroid load, inhaled corticosteroid load, using a PRN. So reducing the risk of severe exacerbations, and that's what the Sigma study showed, as well as the New Zealand practical and the other one showed that it was just effective as in reducing severe exacerbations, and probably cheaper for patients. And I think in the current economic climate, we do need to think about the cost to patients. And then only a few would be stepping up to medium to high dose inhaled corticosteroid LABA, perhaps adding in the tiotropium at that level if they're still not well controlled, and then referral to a specialist if they're not controlled, for consideration of use of or adding in the MABs. The other important thing to note on this diagram is the arrows going down again. That when a patient has been controlled, they haven't had any symptoms for 2 or 3 months, they should be stepped down to a lower dose inhaled corticosteroid, or step down to just an ICS regular use, or the Symbicort PRN. So stepping up when appropriate and stepping down if they've been well controlled for 2 or 3 months. And this is just highlighting that in a little bit bigger so you can see it on the screen. This is where most of your patients should be on a low dose ICS, just ICS, and salbutamol as a reliever, or the PRN Symbicort, because that's the only one that's approved. So we've got the two options. And I'm seeing, and certainly patients, I think a lot of patients are emotionally attached to their SABA, to salbutamol. They carry it around with them everywhere. I watch patients at the gym or at the kids and grandkids swimming, and they're sort of puffing it away, but they're getting very, very little because their technique is appalling. One of the other, and I've mentioned the over-reliance of SABAs, and I'm leading in Australia the Asthma Right Care movement, which is lots of resources available through the International Primary Care Respiratory Group, which I'm on, to highlight this over-reliance of SABAs and underuse of inhaled corticosteroids. And we've got some tools which you can get from the National Asthma Council, an asthma slide rule, which helps to calculate how many doses or their sort of number of canisters per year that patients are using their SABAs. And I often ask in these presentations, what would you consider appropriate use number of canisters per year that a patient should be using if they have well-controlled asthma? So the number of actual canisters, thinking that there's 200 puffs in a salbutamol PMDI. And if you think of the NAC definition of good control of asthma, how many canisters per year? If you want to quickly put it in the questions or the chat box. But the answer is two canisters per year. And it's been shown, and the data is a little bit old, but it's been replicated many, many times, or the initial data, it's back in '89, it's been replicated many times, that if a patient is using 3 or more canisters per year, they have, that's an indication of poorly controlled asthma. And if they're using 12 or more canisters per year, that's essentially 1 a month, and many, many patients are doing that. That significantly increases the risk of death. So a 4 to 5-fold increased risk of death if they're overusing their SABAs. So it's a good question perhaps for pharmacists to ask, especially as we have over-the-counter SABAs available. Patients do find it convenient just to go into the pharmacy and ask for a Ventolin or Asmol. And keeping track of that, I think, is an important role for pharmacists, but also a question for prescribers to ask and nurse practitioners to ask patients, how many have they used in the last 6 months, 12 months? And this is just some of the data identifying that. So patient with mild asthma, the risks, people think, oh, I only get, and I'm not talking about exercise-induced bronchoconstriction here, but I'm talking about people with so-called mild asthma. But our Australian data, so last year there was 417 deaths from asthma, and 15 to 20% of those were with adults that considered that they had mild asthma. So we shouldn't think mild asthma, we don't tend to use the terms mild, moderate and severe anymore, but because it's all about control. But the risks there of having a near fatal asthma attack or dying from asthma is still significant in people that have so-called mild asthma. And the reasons, this is just a number of the reasons why that overuse, over-reliance on SABAs can actually have the down-regulation of beta-2 receptors, has that sort of paradoxical hyper-responsiveness, the rebound bronchoconstriction, increasing eosinophilic airway inflammation, and we really need to be proactive around that. In 2017, we had over 13.5 million. We've only got 26 million people in Australia. 13.5 million SABAs dispensed over the year. And if you think about these usage, 12 more canisters a year increases the risk of flare-ups. 12 or more increases the risk of death. So I think that's something we need to be proactive, any health professional talking to patients around, because there is this inverse relationship. So with the number of canisters of SABAs, that increased risk of death. And the more that you're using, so even with, so that we should be using inhaled corticosteroids once a month, so they should ideally be using 12 in a year. And you can see this, it's around about 4, the increase if they're using less than 4 in a year, so poor adherence, that ratio, or sort of cut-off ratio, is there. So that's a bit of a snapshot on asthma management, what the guidelines say, the medicines that are used for treatment of asthma. So is there any questions at this stage on that, or comments you might like to make before I start going into the technique for asthma? Nope, okay, I can't see any. But feel free to keep asking questions if they're. So inhaled medicines are really the mainstay of treatment of asthma and COPD. They deliver small doses directly to the airways. There is minimal systemic absorption, and therefore those risks of associated with prednisone or prednisolone are very, very, very small compared to inhaled corticosteroids, because they go straight to the lungs. They're straight to the site of action. But the biggest problem we have is that patients don't use them correctly. It's been shown up to 94% of patients don't use every step in the technique correctly, which is pretty astounding. But reality is, we shouldn't underestimate how challenging it can be for patients, especially PMDIs, the mid-dose inhalers, to get that coordination between inhalation and actuation. And I think that's one of the advantages of the growing number of the dry powder inhalers, DPIs, that are available. But nevertheless, there's lots of things they do wrong with DPIs and the soft mist inhalers as well. Sadly, there's also been evidence that health professionals, you and I, don't know how to use all these inhaler devices properly. And in my face-to-face presentations, as well as teaching into 3 unis, I often ask the audience to demonstrate it, and how they using placebos, how to use it. And I guess I'm never cease to be, well, I'm not surprised and am disappointed at times that we don't know how to use them. So it's great that you're on this webinar and are interested in making sure that you know how to use these devices. But it is essential that we demonstrate it, or get the patient to demonstrate it to us, whether it's when you're prescribing. Practice nurses can do it, nurse prescribers, and certainly pharmacists when we're dispensing the medicines to patients. I do home medicine reviews, and the GPs, I get a lot of referrals from GPs for patients with asthma and COPD, and I spend a lot of times, I can spend 20-30 minutes with the patient going through their technique, demonstrating it correctly, using placebos myself. I sometimes, most often, will show the videos to the patient, and then I'll print out the step for their particular device, highlight the steps in the correct technique that perhaps they're not doing as well as they can, and just reassure patients and help them to know exactly, for example, how much inspiratory effort they need to use. And this last line, matching the right inhaler to the right patient, is the key to ensuring effective therapy and good compliance. So the GPs are happy for me to recommend in my home medicine reviews that perhaps the patient really can't use whatever device they're currently using, and they're more comfortable using a different device. And it might be the difference between using, for example, a Breezhailer, which requires a degree of dexterity to get the capsule out of the foil pack and pop it into the device. And perhaps they're more comfortable, for example, with an Ellipta, which might fit more nicely in their hand. So we need to think about the patient's dexterity as well as their cognition. And it's been shown that patients have a natural inhalation technique. So just working through, are they more suited to a PMDI or a soft mist inhaler or a dry powder inhaler? It's the three sort of categories of different types of inhalers. I quite often get asked at these sort of presentations, what's the best one? I don't think there is a best one. The best one is the one that the patient can use. And they've all got the things that patients do wrong, and I'm sure we've all got stories of perhaps amusing but also critical things that patients do wrong. So the consequences of incorrect device use is that with the inhaled corticosteroids, they might get increased deposition in the oropharyngeal area, which increases the risk of oral thrush or dysphonia, and that can lead, because all impacted on the back of the throat rather than going down to the lungs, they get reduced deposition of the drugs in their lungs. The loss of short-acting beta-2 agonist effect leading to, because as I mentioned, that overuse and poor asthma control, and that can lead to presentations to GPs, to emergency departments, and reduced quality of life. And sadly, I was just reading on social media that a young boy died of asthma today. And you know, the drugs that we've got, the technology that we've got these days, I don't know the circumstances around it, but you know, we should be doing everything we can to prevent that. So the different types of inhalers, as I just said before, we've got the PMDIs. There's also the breath-activated PMDIs, which I actually don't even have a sample of. And that's the auto inhaler, and they can be useful in patients that have or really can't master that coordination between inhalation and actuation. Then the dry powder inhalers, and there's basically three different types of dry powder inhalers. The multi-dose ones, which can be like an Actuahaler, where they actually inside the device have a foil pack, and the metered dose is contained within that foil, just like an oral tablet. And that may be more useful. I know I go up to Cairns a fair bit, and with the humidity up there, there are some benefits of having those sort of foil blister packs within, like an Actuahaler. And Ellipta, I was just trying to think the other one, and Ellipta can be beneficial where they've got high humidity. And then you've got devices that have a reservoir, so the whole 60 or 120 doses, and that's with Genuairs and Turbihalers and Spiromaxes. All the doses are contained within a reservoir within the device. And then the third type is the capsule types, which would be the Handihaler, the Zondas, and the Breezhailers, where there's a capsule, separate capsule, which are then put into the device and used properly. And lastly, the other category is the soft mist inhalers. The only one we have is the Respimite, which has some benefits in that it's a slow-moving mist. It doesn't contain a propellant. And I think we should be thinking about the environmental impact of inhaler devices, as well as all the other considerations. So it's a soft-moving mist, so the coordination required between inhalation and actuation is not as critical as a PMDI. So yes, we've got those 3 different types of inhalers available, but you can break it down. There's basically 8 steps to using an inhaler device, and this is I think a simple way for us to think about it in the way that we explain it to patients, but also to help patients understand, because many patients will be on multiple inhalers, and just like we have polypharmacy, we have poly devices as well. And it's no wonder patients get confused if they're on, if they might have their SABA PMDI and then a dry powder inhaler, and then maybe a Respimat, a soft mist inhaler. And that can be confusing because the technique between those 3 different devices can be different. So basically the first step is prepare the inhaler device. Lots of the devices, mostly the PMDIs, need priming before use, as well as the SMI. Some of the dry powder inhalers, like a Turbuhaler, does need priming, and it needs to be turned and clicked twice, so there's 2 extra doses in the device. Prepare or load the device. That might mean getting the capsule out and loading it, or opening up the device, checking the dose counter. One of the steps that many patients forget to do, because I think partly because they don't understand why. And I always explain it to patients that you need to empty your lungs before you can fill your lungs. And usually I've got a glass of water or a bottle of water there, and I say if it's half full, you're only going to be topping up that half. Whereas if it's empty, you don't, as you know, you always have a residual volume, perhaps a little bit like that, about 10 to 20%, that you are able to take a deeper and more stronger breath in associated with it. So breathe out away from the device. With the dry powder inhalers, that's especially critical, and the ones that have reservoirs, because it can cause that moisture and sort of clog up. So I still tell patients when they're using a PMDI to breathe away from the device, just getting them to use the same sort of steps and not giving different steps for different devices. Then you put the inhaler in the mouth or between the teeth without clamping down. And I have seen patients actually have their teeth clenched and then use the inhaler. So between the teeth, don't bite down, form a good seal with the lips, and then breathe in. And this is where it's really critical step, and there's a difference between PMDIs and SMIs and dry powder inhalers. So with PMDIs and the soft mist inhaler, the Respimat, it needs to be a slow, steady, and deep inhalation. Ideally, I mean, patients should be using spacers with PMDIs, but we know they don't, or don't always. So it needs to be, yes, it comes out as a fast spray, very high velocity, that's about 30 miles per hour, slow, as a slow moving car. So patients breathe in automatically quickly because it comes out quickly. And it's only a short duration, and hence that it's about a quarter of a second, 0.25 of a second. But we've got to train them to say, yes, that it's a slow, steady inhalation. And ideally, it should be over 4 to 5 seconds that they breathe in if they're using it without a spacer. And the same with the soft mist inhaler, the Respimat, it needs to be that slow, steady inhalation. You're going to get less impaction on the back of the throat. That's important for inhaled corticosteroids. But for any of the molecules, you want it going down into the lungs and not deposited in the oropharyngeal area. Whereas with dry powder inhalers, all of the dry powder inhalers, you need to inhale quick and deep. It's absolutely critical that patients breathe out so that they then can take a quick, deep breath in. And it's not building up to a deep breath. I've seen that many patients, they go like that, sort of building up. it's that first second is critical for the deagglomeration. That's why within the dry powder inhalers, there's the active ingredient, which is a small particle size between 1 and 5 microns. And then you've got excipients, which is largely lactose, and they're 10 to 20 micron size. And they have to be in there because you're talking about, micrograms of drug. So the reason you have to inhale quick is that forceful inhalation separates the active ingredient, the small particles, from the excipients, the lactose, which you don't want going down to the lungs. That is impacted or remains in the mouth and oropharyngeal area. So that deep breath in is very important with dry powder inhalers. And we do need to train patients and demonstrate it ourselves and perhaps overemphasize it, that's important. And I also check a lot of patients, look for, are they using their accessory muscles? Are they sort of hunching their shoulders to take that deep inhalation? Because that's actually quite a shallow breath, and they should be using their diaphragm, their muscles, the diaphragmatic breathing, and that's a much deeper breath. So telling patients to put their hand on their tummy and seeing that it goes out as they take that deep breath in. So they're really critical, and if you break it down, hopefully you can see that simple way to explain to patients and using the same words. So with SMIs and metered-dose inhalers, a slow, steady and deep inhalation over 4 to 5 seconds, whereas the dry powder inhalers is a quick and deep inhalation over 2 to 3 seconds. Then remove the inhaler from your mouth, hold your breath for up to 5 to 10 seconds. And I demonstrate it to patients counting on your fingers, because otherwise you go 1, 2, 3, 4, 5, which is not 5 seconds, and holding your breath. And I help patients to understand why you need to do that, is saying it's like snowflakes, that molecule, that very small particles, you need to let gravity help to getting those particles down into the small airways of the lungs. Because if you breathe out straight away, you see people do that, they take a quick breath in and a quick breath out, that you might breathe out some of the small particles which you want to go down into the airways. Then wait, 30 seconds really doesn't need to be that long, and repeat if you need 2 doses. So basically, the recommended dose for the PMDIs and SMIs is 2 puffs, whereas the recommended dose for most, or the most usual recommended dose for the dry powder inhalers is 1 inhalation, once or twice a day. So general tips, dry powder inhalers don't need to be shaken. In fact, if you drop them, you can lose the dose. If you've already loaded the dose and for whatever reasons drop it, they should reload another dose. The breath hold is important with dry powder inhalers, breathing away from the device. And if there is a capsule, like with the Handihaler, Zonda and Breezhailer, it needs to be pierced, and I'll demonstrate that soon. The metered dose inhalers, most need to be shaken, and it is getting a little bit confusing because we have got a number now, the Alvesco and Foster, which is and Trimbo, which is solutions rather than suspensions, and therefore don't need to be shaken. There's no harm in shaking them. So to be honest, I still tell patients to shake it, because trying to keep it simple, trying to get them to do the same steps with all of them. Does need to be held upright when you're using it. I have seen patients trying to use it this way, and the reasons should be obvious why you shouldn't use it that way. A spacer should be used with metered dose inhalers and a mask for younger children. And I find I'd go to aged care facilities and some older patients, even using a spacer will use a mask as well. So this is just a checklist. I won't go through it in any detail. And this is using with a spacer. There's lots of different types of spacers. Hopefully when you're first prescribing this to patients, we should be saying to use a spacer just to get them in the habit of it, but reality is people tend to use it without spacers. Although I find, and in nursing homes, the staff are very good, and in hospital environment telling people to use it with a spacer. There's two ways to use it with a spacer, is either the taking one slow inhalation, so actuating one puff, only one puff into the spacer, and then breathing in that slow, steady and deep inhalation over 4 to 5 seconds if possible, holding the breath for 5 seconds afterwards, or using tidal breathing, where you're breathing in and out into the spacer 4 times. Important that there's only one puff in the spacer at any one time, and then to shake it again before using the second puff into the inhaler. And even in the acute situation or so-called first aid situation, where you might be using 4 puffs of Ventolin, it's still one puff at a time into the spacer. The critical thing if they're using without a spacer is that timing between actuation and inhalation. So getting the patients to practice in front of you, to start breathing in as that slow, steady inhalation. And just as you start to breathe in, then press down and continue to keep breathing in. Don't stop as soon as that is actuated. It really does need a lot of reinforcing with patients if they're using it without a spacer. And some people just simply can't get the hang of doing that slow, steady inhalation just as you start, just as it's pressed down. In between doses, we say to, I think it's fortunate that, as I said earlier, that most, so this is a Ventolin and the Zemprion, the generic one has a dose counter. As you can see, it's on the back with the different, I might just switch so you can see them closer. With the Rappihaler, it does have the dose counter on the top. The Flutiform, you can see the dose counter there, hopefully. The newer Breezhailer one has a dose counter on the top. And some of these other generic ones still don't have a dose counter, the Sittlers, although some of the ICS Lava ones, dose counters do. The Alvesco doesn't have a dose counter, old Alvesco. So Alvesco does have some benefits, is because it's a prodrug and has to be converted to the active ingredient in the lungs. So for people that do get dysphonia or perhaps a lot of oral thrush, despite rinsing there and gargling afterwards, and Alvesco does have some, or may have some benefits in patients. So lots of different devices. It is important to tell patients to keep the, or to put the mouthpiece cap back on. I did have a patient who, you know, as most people do, carry it with them all the time. It was a guy, kept it in his pocket. He didn't have the mouthpiece cover. He also chewed gum a lot, and he presented to ED, and he'd actually, on X-ray, he'd actually inhaled some of the foil from his gum because it was stuck into or sitting inside the inhaler there. So yes, they should always put that cap back on and check that there's nothing there before they have the dose. Patients should wait a couple of minutes or sort of 30 seconds or less in between doses. And it's not so that we used to say that it has time, give the first dose time to actually work. And that's not the reason. The reason is the temperature. So the newer, been around for quite a while now, for 20 years, the CFC-free inhaler devices aren't as cold. If you've ever played with it, it's actually quite cold, the aerosol that comes out of it. The CFC ones were even colder. They're about minus 40 degrees. These are only about minus 10 degrees. And the reason you should wait 10 to 30 seconds in between is not because you're waiting for it to work, it's because you're waiting for the temperature to warm up in the nozzle, which you may be able to see inside, which way am I turning? Inside there, it can be a little bit frosty, and you're just waiting for that because that can clog up the device. I can see somebody asking about where do you get dummy inhalers from. The reps, the pharma reps will get them to you. I think just ask them, as well as the sample packs with the active ingredients in it. As a pharmacist, I get a lot from, the only place I get them from is from pharma, from the reps, and in my experience, they're happy to give you a couple of dozen of them, sort of thing. I know this is a National Asthma Council presentation, but I also do work for the Lung Foundation Australia, and they, prior to COVID, were putting on workshops, and they would give you a box of one of each placebo devices. And I also put on my own inhaler device technique workshops over 2 to 4 hours. And through my company called Pharma Education, so you can just go to my website and see that. So, but I think the easiest thing is to ask the reps to give you some placebo devices. So the next, I'll just go back to the screen, I hope, is the Actualer. Actuahalers have been around for quite a while now. They're a dry powder inhaler, and as I said, and this is a placebo one, and you may be able to see inside, there's foil, and each of the metered dose is contained like in a blister pack in between in that round. And then when you open the device, so this is the technique, I will go back to full screen. You open it by putting your thumb in that grip, and that opens, you can then see the mouthpiece. Then press down on the lever, and that actually loads the dose. And what that does when you're moving the lever down, it rotates the foil through some cogs, which you may be able to see there, and that strips the top of the foil pack off, puts the metered dose into a dose chamber up here, and then the empty part foil goes round to this other side here. Okay, so it is beneficial in high humidity areas because each individual dose, the metered dose, is contained within that foil pack. So if you're in a high humidity area, most of you aren't, but nevertheless, it's beneficial. So I was demonstrating it. You should be doing. I'm left-handed, so I'm trying to. It looks a bit clumsy, so I'm trying to demonstrate it right-handed. When you're loading the dose, it should be horizontal, and that's because of when the metered dose is popped into that dose inhaler, the dose little what's the word? Little chamber. That's the word I'm looking for. It's there. It's horizontal. If you did drop it or tip it upside down, you would lose the dose. So holding it horizontal reality is there's a little bit of wriggle room. A lot of the studies have shown it's about 45 degrees either way, but I always will demonstrate it and show to patients holding it horizontally, breathe out away from the device, and then that quick deep breath in, holding the breath for 5 to 10 seconds, going through counting, and then breathe out gently away from the device, and then closing the mouthpiece cover. Most patients, they're only having one dose there. The next, any questions on that? No? I don't have, as I said, an autohaler to demonstrate. And the difference, it's still a metered dose inhaler, but when you open up the mouthpiece cover, pull it down until it clicks, still needs to be shaken because it's a suspension inside the metered dose canister. You push that lever up, and that actually actuates and delivers the dose into the dosing chamber. Open and breathe out gently away from the inhaler, put it between the mouth, and then breathe in slowly and deeply. And that breath in actually actuates it, and you hear that click. The dose lever at the top goes back, but you need to tell patients to keep breathing in after they hear the click. Their automatic reaction is to stop breathing in as soon as they hear the click. They need to keep breathing in that slow, steady inhalation for 4 to 5 seconds. Hold the breath for 5 to 10 seconds, breathe out gently away from the device, and then load it again, shake it again. It is important with metered dose inhalers to shake it in between each of the doses. And that's because the majority of them are suspensions, and as little as 30 seconds, that has, if you think of a suspension like in a kids antibiotic mixture, in as little as 30 seconds, it's sunk to the bottom. So you'll be getting an increased dose. It may also clog up the nozzle because you've got too much of the active ingredient there. And then perhaps halfway through the use of the canister, you've got very little active ingredient, so you're not getting the full dose, full metered dose of the inhaler. So important to tell people to shake it. And there's been studies that have been shown that you need to, it's through 15 centimeters, so it's a sort of, a significant shake, and 4 to 5 times. You see people just do a wussy little shake. It's quite a vigorous shake, 4 to 5 times up and down. Okay, so moving on now to a Breezhailer Handihaler and Zonda, and I've grouped them there together in the interest of time of showing them all. These are ones, they all have a capsule. So you need to take the capsule out of either the foil pack or the device. So with the Zonda, it actually comes in a bottle, so-called child-proof bottle, which is challenging to open. And you can see the size of the capsule. And that's why I say the use of these capsule dry powder inhalers can be challenging for people with dexterity problems, with arthritis, with Parkinson's disease, post-stroke, whatever. And then it needs to be popped into opening up the, again, I'm left-handed, I'm trying to do it right-handed. Opening up the top and popping it in. It is important to demonstrate this because the capsule does fit down the mouthpiece, and then clearly if they inhaled, they'd be inhaling the whole capsule, which they could choke on. So with the Zonda, the dose chamber is vertical, and it needs to be popped in there. Close the mouthpiece, don't shake it, breathe gently away from the device, and I'll demonstrate this properly so that you can hear the capsule rattling. So hopefully you could hear that, and that's a good indication. Now, I should have shown that you need to pierce. I'll go through it step by step. So popping in the capsule into the chamber, closing the mouthpiece, breathing out away from the device, piercing it only once, and then taking that quick deep breath in so that the capsule vibrates. Continue to breathe in that 2 to 3 seconds, and then hold your breath for 5 seconds or longer, and then breathe out away from the device. You can have a second dose. Don't pierce the capsule again, just to make sure. And then when you take it out, you may, because it's a clear capsule, see that there's still some powder remaining in it. It is important for the patient then to dispose of the capsule. I have seen people trying to jam extra ones in there. So the Zonda comes as a closed container, and they get a new one each month. Whereas the Handihaler, which has been around for ages, has, as you know, you open it up and pop in the capsule there. Again, you hear that rattling if you're using it. You only need to press the holder and release it only once. And the thing, because this is not disposable, patients should get a new Handihaler once a year. And it's important that they wash this out once a month. I tell patients to do it on the 1st of every month as a reminder. And you do that by pressing the lever and opening up the bottom. So it ends up as four sections. And then they should rinse this after they've had their dose, rinse it in warm soapy water, just as you would with a spacer. Allow it to air dry. Don't use a tea towel. Don't try to wash up. Don't put it in a dishwasher or anything. And then it will be dry by the time they have their dose the next morning. So, remind patients that that is appropriate. Should get a new one every 12 months, and that's because when you press in the lever, there's a metal prong that pierces the capsule, and that gets blunt. Clearly, if you're using that 365 times, that may get blunt. So patients should get a new one once a year. And similarly with the Breezhailer, it comes with, it's tiny, comes with a little capsule. I've got one in here. Capsule, whoops, you can see it there. And it goes in, the chamber in that is horizontal, you may be able to see that. And it can actually, if you pop it in, throw it in, it can not drop down into the chamber. So I tell patients to close the mouthpiece and then just tap it on the table. And that will then enable the capsule to go down into that horizontal chamber. This has a dose piercer on each side. Press it only once, and the same technique. And you can hear the rattle there. Open up the mouthpiece cover, take out the capsule, dispose of that, and that will last a month. The same thing, the capsule will fit down the dose chamber there. I sometimes think telling people not to do something gives them the idea that they should do it, but nevertheless, I do reinforce to patients that not to, how important it is to put it into that dose chamber. So that is the capsule dry powder inhalers. Are there any questions as I go through them? Nope. Okay, so we've now got the Ellipta, and there's 5 different ones. We've got annuity, which is an ICS by itself, different combinations, Llama by itself, a Llama Laba, ICS Laba, and Trelegy, the ICS Llama Laba. But I do find for some patients they like the look, the feel of an Ellipta. It does fit into your hand quite nicely. One of the advantages, I think, is that the dose counter is quite large. You can see hopefully the 26 there. So that can be beneficial, whereas the dose counter on lots of the others is really quite small and challenging, although they do tend to go red when it's empty. So with the Ellipta, opening it up, which also loads the dose. So that act of pulling down the mouthpiece cover loads the dose. You do need to pull it down. You might have heard that click. The thing to recognise that patients do wrong with Elliptas is that they might put their fingers over the vents. It's not inconceivable that they're holding it like that, although the grip holders tend to do it there. So I do tell patients, don't put your finger or thumb over that vent. So because you sort of open the mouthpiece cover and that loads the device at the same time, it's sort of less steps for the patient to do. Same sort of thing, putting them out. It doesn't have a very long mouthpiece, and some patients aren't like that. I did have one patient who was really putting the whole device into his mouth, so like that. And that compromised his ability to breathe in, and he wasn't forming a good seal with his lips. So, whereas other patients, like the feel of the smaller mouthpiece. Breathe in quick and deep, holding your breath 5 to 10 seconds afterwards, then closing it up. And every time that you open the mouthpiece cover, you can see it counts down. That's gone down to 25. And in one that is finished, you can see it's red, but it will still work. And patients, and I have had some patients that didn't realise that red meant it was empty. So I think we need to be explicit when we're talking to patients around it. The drug company does hand out these whistle devices, and there's no even placebo in these. And that is the minimum inspiratory flow rate to get sufficient to deagglomerate the powder, the active ingredient from the excipients there. So that gives some idea. I would stress that that's the minimum inspiratory flow rate, whereas the optimal is more like this. Okay, so you can perhaps hear the difference in the tone there. The Elliptas do have the same foil inside them, so they have 2 separate chambers. For the dual combination products, they'll have active ingredient in one side, in one foil pack, and the other active ingredient in the other foil pack. Clearly, with the single ones like the Honora, the umeclidinium one and the Annuity, there's just one, so the other side is empty. And with the triple, the Trelegy, there's sort of 2 active ingredients in one side. It's just pedantics. It doesn't really matter to the patient. So that's the Ellipta. The next, I'll just quickly go back to the demonstrations, the slides. The next one is the Genuaire. Now, it's a reservoir one, so it has all of the 60 doses in a reservoir within the device. And when you activate it by pressing down on the lever, that loads a dose, and it actually goes, I think, into a really cool mechanism. There's 25 different parts inside a Genuaire, and it goes into a horizontal chamber, and it has this cyclone mechanism at the where the mouthpiece is, that actually assists with that deagglomeration, the separation of the powder from the active ingredient. So the I'll go to the full screen. As you can see, with the Genuair, there's a dose counter up the top, and that's partly, you can see it's black, so that's down to 40 doses remaining. When it gets down to 20 doses remaining, it's a sort of hashed red and white, and then when it's fully finished, it's completely red. So it should be held horizontally. Remove the mouth cap, check to see that there's no dust or debris in it. Holding it horizontally is to press down on the button and release it. And you'll see that it is, the little window here is green. It's important to release it. I had a patient who was actually a nurse who came to me, and she was, so I run a respiratory clinic in the GP practice, and she said to me, and I've been using this, and she had asthma, COPD, so she was using it for both. And it doesn't seem to be working very well, and I've had it for a couple of months and whatever, and I could see that it was still on 60, and she wasn't releasing it each time. And the point is that when you're using it, breathe out away from the device, and I'll move in a bit closer. So it's now on green, and you'll hear a click. You hear the click, but again, people's natural reaction is to stop breathing in when you hear a click. You need to tell them to keep inhaling after you hear the click. And you can see now it's gone to red. And that shows, and if you had very poor inspiratory flow, it wouldn't activate, it wouldn't click and go over to green. So that's the minimum inspiratory, which is about 30 litres per second, is there. So that is the way. It's the same thing, holding your breath afterwards, counting on your fingers to 5 to 10 seconds afterwards, replacing the mouth, wiping it around, so taking off your lipstick, wiping and replacing it there for the next dose. Now, one of the things I really like about the Genuair is the fact that when it's empty, the last dose that you administer, that you can see how it's popped right up again, that stays down and it won't work, okay? So yes, it's gone to 0 on the, really can't see it, gone to 0 on the dose counter, but it won't work. So I think that's a benefit for some patients, especially if they can't read the dose meter effectively. There are vents on the side. There's 2 little vents, one on either side, just where my fingers are. But it is pretty challenging to cover those up. But again, just make sure that people would naturally be holding it like that and forming a good seal with their lips, because it's got a nice large mouthpiece cover there. I'll go back to showing my slides. The next device is the Respimat. Any questions with that? No. The next device is the Respimat. Now, I'm sure you're aware that it's changed early this January, or December, January last year, and it looks different. This is the older one, this one. And now we have this so-called reusable Respimat. So the first time a pharmacist will dispense it, they will get as the device plus the cartridge, and then on subsequent repeats they will just get the cartridge. So the following 5, if you've written 5 repeats, just get the cartridge. So the important thing here is I think it's a pharmacist's role, but certainly doctors and nurses should be demonstrating it to patients as well, how to load and prime it. And especially now that we do have the reusable one, and they're not getting the device each time, some patients may be doing it themselves. So pharmacists might tell the patient to bring it back in to the pharmacy when they're getting their repeat. Others will, patients forget and don't do it. So they need to be proficient at loading it themselves. So it'll come like that. And the way to do it is to just press down on the side. The clear bottom chamber comes up. They need to insert the cartridge. And then it can be quite hard, insert it on the desk and press down so that it's not fully flush, but that's as far in as it goes. Then put the clear chamber back on the top, and you can see now the dose counter is on the bottom. Before, it had a slide up the side that went up to red. It now has a dose counter on the bottom, so starting at 60 and going down. Because it's reusable, you may see the little 6 dots on the side. So every time the patient reloads it, you should get them to tick it off, or tick it off yourself for the pharmacist if you're doing it in the pharmacy for them, to tick it off there. Then need to prime it, and only needs to be primed initially, or if it hasn't been used for a few days. Ideally, it should be used every day. But it needs to be primed. So the way to prime it is to rotate it. It's a half rotate until it clicks. Then open up the dose cover and holding it away from you, because you're priming it. And I'll do it there so that you can see it. And then press down on the grey nozzle, and you can see it's a slow moving mist over 1.5 seconds. There's no aerosol in it. It's just the mechanism inside the two little chambers, again intersecting a cyclone mechanism that is at 90 degrees, and it just forces out this lovely slow moving aerosol. Need to close the top, turn it again, and do that 4 times. Okay, so that's priming it. Because I've used this, the very first time you might not get hardly any mist coming out, and that just really sort of reinforces how critical it is to prime the device. So that's all loaded and primed and ready to go. The technique is similar, so just turning it, that half click, holding it horizontal, opening it, the mouthpiece cover, breathing out away from the device, putting it between your teeth, forming a good seal with your lips. Closing the mouthpiece cover again. Okay, so that's, and the same thing, people's reaction is to stop as soon as they press the button down, but trying to get them to do, keep breathing in that 4 to 5 seconds after they have released the dose. And then need to have a second dose, doing the same technique. There's no need to shake this device, so that's really there. So I think it is a good device, but especially for people that have some challenges and don't want to use a spacer with the PMDIs, and the fact that it's that slow-moving mist, and if you can get the patients to, we don't have a product with an inhaled corticosteroid in it, but I was just looking at the questions about the slides. I think it's in National Asthma Council's policy that these slides aren't given out, but perhaps Jenny at the PHN can check on that. And usually this video of the webinar is available on the PHN website for a month after the presentation. But there are checklists available. As I said, both the National Asthma, Cancer and Lung Foundation have checklists for each individual device. The MPS Medicine-wise has a sort of a cheat sheet, if you like, on all of the devices, and you may have seen it. It's got them all listed two-sided now because there's so many, and it goes through each of these sort of 8 steps for each of the devices. And you can just go to the MPS Medicine-wise to get that checklist there. Or you could email me directly. I'm happy to send things to people. And my email is just my name, drigby@bigpond.net.au. I'm happy to do that, or go to my website. So that's the Respimat. And there's also an improvement in, because the patient now needs to load in the repeat, so the next cartridge, that there's this demonstration device which you can get from the reps, and what it shows on the 60th dose of the Respimat, it automatically pops out. So it's not up to the patient to try to pull it out. And this is just a demonstration device. And what you may be able to see if I hold it up, on the last time that you turn it, it pops out automatically. So there's no risk of a patient continuing to use it, because that 60th dose, or it's actually 64th dose because it has those extra ones in for priming, but don't tell patients that, it pops out. So it's ready to load the next device next cartridge into the device. Okay, how are we going for time? Very quickly, the last one is the Spiromax and Turbuhaler. They are A-flagged, as I said. They're both dry powder inhalers. I think one of the challenges with the Spiromax is that it actually it has the look and feel of a PMDI, but it in fact is a dry powder inhaler. So demonstrating it, same thing, when you open the mouthpiece cover, have to pull it down until it clicks, and that loads the dose because it is a reservoir inside. You can see there that is the air vent. You shouldn't put your fingers over. It does have a nice dose counter on the back, which there's only 10 doses left in this one. So it's gone to red. And then similarly with the Turbuhaler, been around for ages. This one's gone red. The dose counter there is pretty small, challenging to see. It does, the thing I really reinforce with patients with the Turbuhaler is that it needs to be turned and turned back the other way until you hear the click. That needs to be done horizontally because of the mechanism. The reservoir is up and down there, and then it drops down into a tray which has got 5 sections, and that's the metered dose, which then goes up through this cool sort of twisting cyclone mechanism to de-agglomerate it, separate it out, sort of thing. So I'll tell patients or I'll demonstrate it to patients on the table that they need to do that activation, loading the dose, turning one way and back until it clicks there. And then same technique, putting it between the teeth without biting, close the lips to form a good seal. Don't put your fingers over the air vents, which is pretty challenging to do because they're little air vents down here on either side. And it should be held horizontally. Again, there's a bit of 45-degree wriggle room, but patients will do all sorts of things. If it is dropped, you need to reload the dose. There's no risk of double dosing because of that 5 trays inside the device there. So just to finish off, I'll just go back to my slides. Is it doing that? Is it going back? Yep. Thank you. Just to finish off around spaces, there's lots of different spaces, including these ones which are not disposable. Schools use them on camps, etc. They're just cardboard. There's the old emergency things of a Coke bottle or a water bottle. Actually fits really nicely, the nozzle of a PMDI. But we should be, as much as we can, telling patients to use the different types. The large volume spacer or the football one shouldn't be used for children because they don't have sufficient lung volume to inhale that amount for sort of under 6-year-olds usually. Children and perhaps older people, especially people with dementia, would benefit from a mask. It needs to be the appropriate size. There's small, medium, large. The newer ones have, what do they call it, silver iron. Spaces do need to be cleaned out and warm soapy water beforehand. They're so beneficial. You can see from these sort of scans the increased lung deposition. Even with perfect technique from just a PMDI, you're only going to get about 10 to 20% lung deposition. Whereas if you're using a spacer with the PMDI, you're going to get up to 50–60% lung deposition. And Asthma Australia has these good little graphics, and they use it on social media to demonstrate the difference in the amount of drug getting into the lungs with those. Care of spaces, as I said, first day of the month, wash it out in warm soapy water. Don't use a tea towel to dry it overnight. Replace it every 6 to 12 months. Again, there's lots of freebies around. I take new ones to patients. I've seen some that's disgustingly dirty and mold inside them. So I will give a patient an inhaler, and some pharmacies will do that too. Nebulizers really shouldn't be used anymore because absolute strong evidence to show that using a PMDI plus a spacer appropriately, good technique, is just as effective as using a nebulizer. So nebulizers really should only be used in severe life-threatening situations in ED or ambulances or whatever. Again, I've got a photo, I haven't put it in, of the tubing, which was yellow and had black mold on it, and the patient was continually using it. So new tubing, new masks, and that increases the cost. So really encouraging and helping patients to understand that a spacer plus with the MDI is just as effective. So these are the resources with the National Asthma Council. There's a huge amount of them. Most you can download and print off yourself, give to patients. As I said, NPS medicine-wise, nps.org.au has lots of resources, and that checklist might be beneficial to a lot of you. So thank you very much for your attention. I've gone a few minutes over time, but I'm happy to take any last questions. And really, I think it behoves all of us as health professionals to think about, are we proficient? Are we at using these devices? Think about what words you use, what to stress to patients, the things to do, things you shouldn't do, the critical errors, and I think perhaps the thing that might be new to you is those two different types of inspiratory flow rate, the quick and deep with dry powder inhalers, or the slow, steady and deep with the PMDIs and with Respimat. And I think if we can simplify, and again using those 8 different steps, helping patients, trying to get them on, if possible, onto the one type of device, and now especially probably more so with COPD, but certainly for patients with moderate to severe asthma, the triple therapy and at least the dual therapy, dual combination products is better than having 3 or 4 or 5 different devices for them. So thank you, and I hope you've learned some stuff that you can put into practice tomorrow. So I'll hand back to you, Jenny.
Thank you so much, Debbie. That was such a comprehensive presentation. Everyone, you'll see the QR code up on your screen now. If you could scan it and complete the evaluation, we'd be very grateful. I will send it out tomorrow as well to everyone that's attended. We do have the last National Asthma Council webinar that we ran a few weeks ago up in our education library. It will only be there, I think, until Monday, and we will put this one up as well, but again, it will only be up for a few weeks as requested by the National Asthma Council. I just wanted to let you know that there's also a document in the library next to the last webinar that has a link to all of the resources that were in Debbie's previous slide. So go and have a look, because I think you'll find it very useful. Oh, on scanning, it says that I have already completed the survey. Well, that's not very good, Victoria. I will definitely get the correct QR code. I'd say that they may have used a previous one if you've attended a previous webinar.
No, when I scanned it, it came up.
Oh, okay. Well, that's good. I will send out the link as well to everybody. Thank you, everyone, for coming. And Debbie, thank you so much for giving up your valuable time. And I will catch everybody next time. Good night.
Good night, everybody.